Thank you. So we'll need to move on to our next speaker. Our next speaker is Dr. Tian. Ye is a senior researcher also from the University of Melbourne. Over to you, Ye.
Thanks, Andrew, for the introduction, and thanks everyone for coming. It's very packed, so it's very glad everyone's here. So today I will talk about immunometabolic dysregulation in depression across illness stage and over the time course, and also look at association with brain structure. So why I'm very interested in this area? Okay, great. Let's start with some epidemiology. As you can see, those studies summarized here, physical illness is disproportionately prevalent in people with mental disorders. On average, or overall, epidemiological studies have shown that people with mental disorders, they have 2 to 3-fold increased risk of chronic conditions, including, for example, heart disease, stroke, and diabetes. They have reduced life expectancy of 20 to 25 years, and most importantly, the majority of years of life lost in those people relates to poor physical health. So despite the emerging or increased awareness of physical comorbidity in psychiatry, treating them still remains a challenge. And why is that? In my opinion, one possibility is that despite all those abundant evidence suggests epidemiological links, we still don't know too much about the biological origins. So in one sentence, people with mental disorder, not only they have disparities in healthcare for them, there's also existing disparities in research to look into the biology to explain what's the biology that can explain the epidemiological links. So for today's talk, I'll mainly focus on depression, despite there's some other work going on. And one of the emerging evidence to indicate or suggest the somatic symptoms of physical comorbidity in depression is immunometabolic dysregulation. If you look at this graph has a very nice summarizing several possible organ systems that are involved in the potential pathophysiology of depression. Although we still don't know the sequence of the events that could lead to the alterations in those interconnected systems, but one hypothesis can be the stress response systems, like alterations in stress response system, including the immune system and HBA axis, could directly and indirectly lead to changes in the central nervous system, for example, inflammation, and leads to mood changes. On the other hand, depression-related behavior changes or something happening in the brain related to depression, they also have downstream effect on the stress response system, the immune system, and HBA axis, and could lead to dysregulation of the metabolic function and leads to dyslipidemia and increased risk of cardiometabolic condition. Speaking of dyslipidemia and the cardiometabolic condition, I think it will be very interesting worth to mention one of the key players, the lipid. So given that we are a neuroimaging community, people may not familiar with this lipid metabolism. So lipids are carried by lipoprotein in the blood. According to the size and density, lipoprotein can be grouped into different subclasses, from the very high density lipoprotein or HDL to very low density lipoprotein or VLDL and chylomicrons. So how do they play a role in the lipoprotein metabolism? So as we all know, the high density lipoprotein or high lipoprotein cholesterol, they consider as good lipoprotein because they play a key role in reverse cholesterol transport, which means that they can transport the unused cholesterol in the blood back to the liver for disposal. In contrast to the considered very bad lipoprotein, the VLDL, they are triglycerides rich and could lead to plaque buildup in arteries, which is one of the main causes of coronary heart disease. How are they related to depression? So in a recent study published a few years ago, there's a study of meta-analysis. So they assessed more than 200 metabolites using metabolomic techniques in depression and look at how the profile changed in depression compared to healthy individuals. So overall, they show that MDD or depression is associated with downregulation of HDL and upregulation of VLDL and associated lipids and triglycerides, and also alterations in a variety of plasma lipids, fatty acids, and low molecule weight metabolites. So this looks very promising. However, This study only included established depression at chronic stage. They might already have 1 or 2 episodes. The question to me remains, as which comes first? Is it immune metabolic dysregulation or depression? Let's imagine a typical illness progression trajectory. People might have some prodromal stage, have some mild symptoms, anxiety, irritability, etc. And then they have full episode of depression. Then they might go through multiple remission or relapse during the chronic stage. So if immunometabolic dysregulation happened at the prodromal stage, it might suggest that immunometabolic disturbances could contribute to the risk of disease development. And if that's the case, which means they can potentially be used to identify high-risk individuals and at a very early stage of depression or subclinical depression. However, if everything is fine during the prodromal stage, only happen at chronic stage, it means that immunometabolic dysfunction may more of a consequence of depression, maybe due to long-term illness or medications or other factors. So to address these questions, in the study we used the UK Biobank because of the rich phenotyping and clinical data. So by looking at their medical records from their primary care and from their hospital records, as well as questionnaires at each study visit, we identified people with established depression or people have been diagnosed with depression at the time of blood sample collection. We grouped them into an existing depression group. In contrast, also have another group called prodromal depression, which means at the time of blood sample collection, they haven't had been diagnosed of depression, but they developed depression later. And of course, as a comparison, we'll have a group of healthy individuals who don't have any disease. We look at the immunometabolic profile in depression across 200 metabolites, across different metabolite categories, including lipids, glucose, and inflammation, and other molecule amino acids, for example. Not did we look at individual markers, also interested in immunometabolic function as a network. How did the network altered in people with depression? We look at the cross-sectional and longitudinal changes of those immunometabolic markers and look at whether they're associated with illness progression and over the course of illness. And finally, we look at if there's a prospective association between immunometabolic dysfunction and brain. So here are some results. So first of all, we show this is consistent with the previous meta-analysis, where we show that depression or existing depression associated upregulation of inflammation, as indicated by CRP, C-reactive protein, and the glycoprotein acetyl, which is another very important systemic inflammatory marker, and VLDL. In contrast, there is a downregulation of the good lipoprotein HDL. This is in existing depression, which is consistent with previous study. And here shows the effect size of alteration in those metabolites. So if you look at the colored bar, they are the effect size in established depression, and the black line in the middle indicate the magnitude of alteration of those markers in prodromal depression. So you can see that even at the prodromal stage, before the full onset of depression, those we already see alterations in those immunometabolic profile, even to a less extent. The magnitude is smaller. However, the pattern is very consistent across categories of metabolites. Not only did we look at individual metabolic markers, we're also very interested in the metabolomic network. So what do I mean is that if you can thinking about metabolism as chains of enzyme catalyzed reactions, so essentially it's a network. So the way we map the network is essentially the same as we map functional brain network. We compute the Pearson correlation coefficient between pairs of metabolites, and we look at whether the functional coupling or strength between pairs of metabolites is altered in depression compared to healthy people. So here are the main findings. As you may notice, so in this graph, the blue edges indicate reduced coupling between metabolites, whereas the red edges indicate increased coupling. So we see very widespread reduced coupling between metabolites, and particularly centered around glucose and lactate related to glycolysis metabolism. So it seems like a key player in this alteration. So even though we still don't know the mechanism still to be unpacked why we see this widespread reduction in the coupling, but it might suggest that the core role of glycolysis, so maybe in the future intervention, if we can normalize glucose metabolism, it might have some added or subsequent benefit in improving the metabolic function and inflammation in general. So that is in the existing depression group. We find the very similar pattern in prodromal depression group. We see the metabolomic network changes as well. And so So this two graph is very similar. It's also consistent with individual markers. So we already see this network level alterations in those metabolites even before the illness onset. So what I have shown you so far is more about a snapshot of what have happened using cross-sectional data. We're also very interested in whether there's a change, whether longitudinal changes in those metabolomic markers is associated with illness duration or the across illness stages. So to do that, we compute the rate of change in each metabolite over 2 time points. So it's available in the UK Biobank where they have 2 time points of blood sample collection, so we can map the rate of change for each metabolite. So we look at whether the rate of change is different across the 3 groups: healthy people, prodromal depression, and existing depression. However, as you can see here, that we don't see much difference in terms of the rate of change, despite we see the widespread differences in individual marker at the using cross-sectional data. So here are only 4 markers that show significant between group differences in terms of rate of change. So I'll just highlight maybe these 2 one. So essentially, we see faster increase in glucose in established depression compared to prodromal depression. And we see a faster decrease in lactate in depression across illness stage, and also a faster decrease compared to healthy individuals. The magnitude of the effect size is relatively small, but it might suggest, but they all so these 2 markers and also pyruvate, they all relate to glucose metabolism. So it's in a way consistent with what we find in the cross-sectional data. And not only do we want to look at that, we also look at whether the concentration or plasma level of those metabolites, they vary as a function of a prodromal stage. So we look at that, but they're not. So it's rather stable. So here I show you a few examples of the rather stable trajectory over the prodromal periods. So I have to mention that the prodromal period we define here is really the time difference between the interval between the blood sample assessment and the diagnosis in the prodromal group. It doesn't necessarily reflect the clinically defined prodromal group, where it's from the time from the occurrence of mild symptoms, prodromal symptoms, to the full depressive onset. But overall, we see a very stable trajectory over time. And we also consider whether or not people already have established metabolic disorders, and that didn't change the trajectory that much. So which suggests that immunometabolic dysfunction may have been established even earlier. And finally, we are interested to look at whether there is a prospective association between baseline metabolites and brain structure at a follow-up. So to do that, we first run a PCR analysis across 200 metabolites, and we'll look at whether the PC component is associated with brain structure and regional brain volume in depression, and whether that association is different compared to healthy people. So for the interest of time, I'm most interested, and we will look at the main factor of diagnosis, main factor of metabolites, and also the interaction. For the interest of time, I only present the significant interaction effect, and then we only find a significant interaction effect for the PC2 component, which is primarily represented by elevated CRP, leukocyte, and also reduced albumin, whereas albumin has anti-inflammatory properties, and CRP is increased CRP indicates increased inflammation. So basically what we find here is increased peripheral inflammation is associated with lower gray matter volume for paracentral and superior parietal lobes in depression, but this association did not exist in healthy individuals. So this is perhaps consistent with inflammation hypothesis in depression, that peripheral inflammation may lead to alteration in central inflammation, and may contribute to depression onset. So as a quick summary, in the study, we use a very large prospective population cohort where we did a very systematic investigation of peripheral immunometabolic dysfunction in depression over time and across illness stages. And interestingly, we see a relatively stable pattern or persistent pattern of immunometabolic dysfunction before and after the onset of depression, and also along the course of illness. Another interesting finding is the systemic changes in depression-related metabolomics, and we identify core role of glycolysis, which can be a potential treatment target in the future. And we provide some preliminary evidence to suggest potential impact of peripheral inflammation, inflammatory dysfunction on brain structure. And this study is really to indicate we need to consider to manage chronic low-grade inflammation and altered lipids and glucose metabolism in depression, not just only focusing on treating the depressive symptoms using antidepressants. And there are many things can be unpacked from this study. I just want to highlight an interesting future direction because I was talking about the hypothesis from the impact from peripheral inflammation to central inflammation. And of course, we need to use a more specific markers for neuroinflammation to unpack this hypothesis. And finally, I would like to thank everyone for your attention and thanks for all the collaborators and here. I don't know if we have time for questions.
Thanks very much. Yeah, that was a fantastic presentation. We can take one quick question from the online app, and the question is: did the prodromal group were they ever diagnosed with a depressive episode before baseline? No, they didn't. We specifically considered, we look at the medical records, not just from the hospital records, and also based on the time, the questionnaire using PHQ at the time of visit. So we exclude people with any, they didn't have diagnosis with depression at the blood sample collection, but they developed depression later. Thanks very much, yeah. We might need to move on to the next speaker given time. Please join me once again in thanking Ye for the fantastic presentation.